Welcome to the Health System CIO Show. I'm your host, Editor-in-Chief Anthony Guerra. On today's episode, I'll be speaking with Dr. Allison Dempsey, Director of Technology and Data Governance at the Brain and Behavior Innovation Center at CU Anschutz. Dr. Dempsey, thanks for joining me today.
Hi, thank you so much for having me. It's a pleasure to be here.
Great. You want to start off by telling me a little bit about your organization and your role?
Sure. First of all, I'm a psychologist and I'm also a researcher, and I'm a professor in the Department of Psychiatry at, as you mentioned, the University of Colorado School of Medicine on the Anschutz Medical Campus. And for the department, I have two roles. I'm the Director of Informatics, and then I'm also Director of Technology and lead our technology pillar of our Brain and Behavior Innovation Center. And then a different hat that I wear, though related, is I'm also the behavioral health representative on UC Health Systems Physician Informatics Group. And for that, I bring the perspective of behavioral health clinicians into their system-wide strategy, governance, optimization efforts, decisions about technology adoption, and so on. So starting with the University of Colorado, the Department of Psychiatry is in Denver on the Anschutz Medical Campus. Our faculty work really extensively with UC Health, though that is a separate system. And UC Health is a large integrated healthcare system, and it provides care across hospitals, ambulatory practices, ED settings, and a wide range of specialty programs. And behavioral health is represented in all of those. This is our largest healthcare system in Colorado as well. So really my role between these two sits at that intersection of those two environments, both the academic innovation part and the real world healthcare implementation part as well.
All right, very good. So, how would you describe at a high level the impact of technology? I know with COVID, there was a lot of remote care started happening. I think we saw a lot of things happening around behavioral health.
Yeah.
Versus sort of the traditional other types of care. As opposed to behavioral health. I don't know how you would describe them and split them up, but we follow that other sort of more traditional side as opposed to the behavioral side. But I think the behavioral side is extremely important. And the context I'll give you here that can help inform this discussion is most of the people that we're serving as readers would be the IT executives at the enterprise health system, the CIOs, the CMIOs, the CISOs, those individuals. And I've found that a helpful way to think about this is they need to lean into different areas of the health system and to better understand how they can support those areas in terms of technology. One area might be revenue cycle. One area might be imaging. Certainly, behavioral health might be an area where they need to specifically lean in and learn and get a better understanding so they can be a better support pillar. It sounds like you're bridging that gap between the clinical care and perhaps some enterprise IT individuals to bring those two together, like a CMIO for behavioral health. Almost sounds like what your role is a bit, but your thoughts?
Yeah, well, first of all, I appreciate the promotion. Thank you. Yeah, I would say, so behavioral health is really interesting. So first of all, maybe not entirely unique to it, but it is very pervasive in terms of where it sits across a healthcare system. It is not just specialty ambulatory practice or an inpatient behavioral health unit. We have behavioral health in our emergency department. We have a lot of cases come in with suicidality or suicide attempts or psychosis that we're addressing in the emergency rooms. We do have our inpatient unit. Of course, we have consultation liaison to different teams on the floors. We have neuromodulation. We even sometimes are in surgical settings as well. And so when we're talking about behavioral health, it's not confined to one environment. It's everywhere. The other thing I think that's really a little more unique about behavioral health is that it has a really long-standing experience with some of the issues that we're facing most today, particularly with the growing emergence of AI. So privacy, consent, trust, sensitive documentation, as well as then some other aspects like longitudinal care and patient-generated information. So what behavioral health is encountering is really prevalent across the enterprise and not just specific to behavioral health, but because we have these additional kind of safety, security, measures when it comes to behavioral health, we often may be the first ones really dealing with these too.
Yeah, that's a great point. That's really interesting. So one of the big dynamics we talk about on the more traditional side is this, and forgive me if that's the wrong way to describe it, but um, is silos. From an IT point of view, it's data silos. This is the big problem that everybody's finding a million ways to fix
Right.
through different ways of doing it. And it sounds like behavioral health has been faced with this challenge forever because it crosses clinical care. So you may need some behavioral care, and you certainly could have underlying clinical issues. You could have substance abuse issues.
Mhm.
So this bigger picture, this desire to break silos, you've been dealing with it for a long time.
Yes, particularly when it comes to technology. When we're evaluating technology, I'm never thinking what is the one clinic this works in? Because I have this informatics role, I'm always having to think, how does this scale? Where does this live in Epic, for example, across different environments in which these clinicians are operating? What do we need to be thinking about? Confidentiality issues of whatever data are generated. Do we have special aspects of consent? Do those carry across settings and so on? So it's what sounds like sometimes a simple innovation that we're doing tends to be much more complex. And so the stakeholders and the governance often involves multiple groups and multiple stages before we can really get to a place where we're ready for a go live.
Yeah, that's a great point. And that is a huge problem in general, not a problem, but one of the dynamics that IT leaders face all the time. It's this reality of being in a suite tied to your EHR, a lot of Epic, some Oracle slash Cerner, some Meditech, but a lot of Epic, right? And the dynamic is what's inside Epic? What do they have that's available that we might need? What's not in Epic but we need? And how do we pick something? And as you said, it's got to come into the fold. It's got to come into the workflow. So, is Epic going to make what we're looking at? When? Right?
Mhm.
What's if Epic has something, compare that functionality to what they have versus this point solution that maybe everybody loves on the clinical side, but you've got the bigger picture view of saying, well, I know you love this, but we have to get it inside the workflow, and that's going to be challenging or not so challenging. So what are some more of your thoughts around balancing all that?
Yes, that is constant. I will say, I think with any sort of innovation that we're working on, we always have to start with it's not about the technology itself. It's really starting with the why. So, what problem is this addressing? Is it worth this lift that there's going to be for this? Because any sort of change, any sort of implementation, there's always a response cost, right? So, you've got the personnel time that needs to go into building it. You need to figure out where the time is coming from in terms of patient workflows, provider workflows. You need to think about how are you upkeeping it. And so you have to be asking, like, is this even worth it to do to make that happen? Are we really willing to invest these resources? And it's, across the board that we see with behavioral health, we do questionnaires for symptom monitoring. And, each provider has their own questionnaire that they like, but it's not so easy to build that into an enterprise system, especially if there's a license for it, for example, because you're not just buying the license for the 5 patients that maybe it's being used on by that provider. You're paying for it to be available to everybody in this large healthcare system, which can be, hundreds of thousands of dollars at times. So that's just an example of something I'm often asked where, well, why can't we build this questionnaire and so I can send it to my patients? Well, it's never that easy to do. And then if there's a risk question on it, do we have a pathway for making sure that there's safety protocols if, a patient endorses some sort of risk variable?
Yeah, do you wind up having to liaise a lot with IT security and CISO type functions? There's so much there, as you said, around privacy, compliance, and all these type of things. So that deals with certain individuals, privacy and compliance individuals. But then you've got sort of IT security where you may, I don't know, you may want a heightened bar for some of this stuff.
Yes.
So you have to work with a lot of folks. And then you're working, as you said, with perhaps if this request for this particular tool came from a clinician,
Mhm.
they're talking to you saying, "Hey, I really like this. Like this would be great." And you're
Mhm.
having to balance all this other stuff. And
Right.
then, as you said, there's governance has to come into play so that the right voices are making an evaluation. And then you need transparency back to the requester of here's why perhaps we're not going to do this right now, but
Right.
it wasn't me, Dr. Dempsey, saying no. It's the governance process
Right.
saying no. So tell me your thoughts about that.
Yeah, I think that's 100% accurate. And that's also why it can take 3 weeks to get an answer because
Right.
it's not just one governance group I'm going to, it may be multiple over time. However, while those can seem, painstaking, like
Yeah.
it's an arduous process to go through,
Right.
it exists for a reason. If you
Right.
don't have the right people weighing in on the front end, you're inevitably going to run into something that is a stop point, or it could even be a no-go decision that you wish you had known right away. Well, we can't do this because it interferes with this law or this security setting or the way that these templates are built. And so you want to start early, really with what teams need to be involved before you even start to go forward with what is this going to look like.
Yeah. And there's a lot of state by state stuff.
Yes.
And I would imagine most organizations of your size wind up dealing with people across states. You probably issues with where the care is being delivered. If someone has traveled to that place to get the care, what is the place they're from? I don't know if that matters, but you could have a lot of things you're trying to privacy laws that you're all trying to reconcile. Um,
Yeah. And is the clinician licensed to provide services in the state that the patient is currently in? Because that is absolutely critical.
what about I've heard this come up in pediatric settings. The granularity of choice that a patient may get about sharing certain data and even certain fields with certain providers at certain times.
Yes.
And it sounds great on paper and maybe to a lawmaker or a politician to be able to grant phenomenal granularity of choice to patients to just say, well, it should be the patient's choice and they should get to do whatever they want and change it whenever they want. That can be difficult to put into practice, especially when you're dealing with vendor systems that, it's not one phone call to Epic or whoever and saying, hey, I want this field over here, over here. Well, these things take time. So do you see sometimes some of these requests or goals that are put out at a high level and you say and you're one of the people that understands the actual implementation of these things is a bit harder than what we would love to be able to do.
Yeah. I would say that's 90% of my day or my job. Um, I'm trying to think of some examples for this. I think one that you pointed out is this kind of health information management piece. So there is this expectation that behavioral health data, and whether or not this is right or not is
Hmm.
questionable because we also feel there's arguments that this stigmatizes access to behavioral health. If you're saying, well, it's something we should hide because it's something that people don't want others to know. It's like, well, no, it's part of healthcare. Brain health, psychiatric health is health too.
Hmm. Hmm.
But there's often these questions of, well, is this, in our language we use behind the wall, so nobody can see if you even have an appointment there. And that's been in the past in reaction to some laws that we've had that said, for example, if you're receiving substance use care, nobody should be able to see it except for your substance use providers. Or is it behind the glass where it has some added protections, but providers need to put in a password if they needed to access a note, for example. And while all of these sound great in practice, it can be a problem if you have a patient who is receiving substance use care, say, come into the emergency room, and the providers there can't see that they're actually receiving treatment or have been given certain diagnoses because it's behind the wall and they don't have access to that. So it can actually, while they sound great in theory, they can be problematic. But then, so whenever there's any sort of new innovation that we're doing or any change we're making in the system, we always have to think, well, additional level of security is this going to require? How does it align with regulatory requirements? But then also, what does this mean for the clinical practice if we put
Mm.
certain security settings on it?
Yeah, and I'm even wondering, you could have a concept, and maybe this is the case where a provider, whether or not the provider should even be able to know there's something there's something behind the wall,
Right.
meaning I could see there's a wall. Well, maybe as a
Yeah.
patient, I don't even want you to know there's a wall because I
Right.
don't want you
And you
looking at
don't know
me.
that there's a wall. That's the issue too. It's not even that there's restricted data. You don't know that it exists.
Right. Either
Yeah.
you do or you don't. Meaning,
Right.
like, so it gets extremely granular.
Yes.
Um, and you're trying to deal with what the patient wants, what the provider needs, what the systems will allow in terms of what's doable.
Correct.
Um,
Yeah.
so it's a lot.
And you can deal with that. It comes into particular play with pediatrics and also adolescent medicine environments because for many things, adolescents can consent for themselves. So they can consent to certain adolescent medicine, activities and care. They can consent to behavioral health, like they can consent to psychotherapy without their parents needing to give consent. But then if there's a medication involved, the parents do have to consent for that. And so it's trying to figure out which of these notes, is hidden, which ones are not, and so on. And then
Yeah.
knowing that if they're billing insurance, the parent still is going to see at the back end that there is a behavioral health visit, with a billed code and diagnosis.
Wow. I mean, you thought that traditional care was complicated.
Yes.
This
Yes.
is really so, to my original sort of question, what do you think that how can enterprise IT better understand this area and better support this area, CIOs and the like? And I don't know how much they know. I don't know how much they lean in. I don't know how much they've had to. Sometimes we talk about this in imaging where there's not as much enterprise imaging work as I would expect to see. Sometimes you see major work going on at certain places, but it's not pervasive. And my theory was that, well, it's really, really complicated. It's a really big lift, and it's kind of working well enough the way it is. So yeah, it could be out. You could break it all down and build it up much better, but you got other things to do, so leave it alone.
Yeah.
And I don't know if that's the kind of thing with behavioral health where it's kind of being handled at a little bit of a lower level. Or do you feel like it is an area that enterprise IT really should learn and lean in, and there are things that can be done?
Yeah, I would say yes, definitely. And I think we're seeing a growing recognition, especially since the pandemic, of how important mental health is. In pediatrics, we have a youth mental health crisis right now. People are always shocked by the statistic that I practice in the women's health space and perinatal space. For example, the number one cause of maternal mortality in this country is suicide.
Wow.
It's not medical complications. It's not hypertension or postpartum stroke. It's suicide. So mental health is not, it's not a moneymaker. And so often, I think for many reasons, it gets lower priority. There aren't many behavioral health informaticists out there in large healthcare systems. I think we're starting to see more and more of that. But as we're seeing this growing recognition of the need for behavioral health and how important it is to incorporate into care, I think there's a call now for these enterprises to actually make sure that they understand what behavioral health needs, what are their specific kind of legislative and regulatory pieces that they're having to follow, what are some of the challenges that they're having working across all these settings too.
Mm-hmm. All right, very good. So Epic, I believe you've just joined the Epic Behavioral Health Steering Board, which is,
Yes.
I think that's what caught my eye. Very interesting. Yep. So sounds like Epic is leaning into behavioral health. If
yes.
they may have been for a while, but this is certainly an indication that they're there. The tools that you use in your work, are these Epic homegrown developed tools, or are they third-party tools that you're able to bring in so you can get integration to some degree between the patient's sort of my chart and their behavioral tool? Is there a Epic behavioral tool, or is it sort of a third-party tool?
There is indeed.
Uh-huh.
So Epic has a behavioral health module.
Mhm.
So Epic's interesting because it was built for really adult medicine to start, right? And behavioral health has kind of been layered on top of that, and some things worked well and some things didn't. So they have come up with a behavioral health tool that does address some very common behavioral health problems. There's, for example, module for behavioral or for group therapy, which it can also be available and used in other settings if you do group visits for medicine, for example. There are treatment plans. So we have specific requirements for treatment plans that we have to use. And so they've taken tools, I believe, from palliative care and care plans over there and used those and kind of adapted them so that they are responsive to behavioral health. And I do believe most of that actually came from the behavioral health sphere, which is made up of practitioners coming in and saying, here's what we need and here's what we can't really work with right now. I think so much of the challenges that we face aren't necessarily something that you need a third party for. Sometimes it's, how do we get a consent to work in this unique situation that nobody else needs a consent for example? How do we, push out patient-facing questionnaires more regularly and not as kind of a one-time screening, but still have a way that we can view and respond to those answers? And then there are some times that a third-party tool may exist out there that we just don't have in Epic, and we will consider and work with our healthcare system to think about, is this something that works? Is this something we can build with our own architecture team and amazing analysts in our system? And my hope is that by joining the steering board, that when there are those big problems where we need solutions and there's just not a way to work around them inside Epic, that rather than going to a different solution, we can go to Epic and work with them to say, this is a pervasive problem, because it's never just contained to one healthcare system. If one of us is experiencing it, most likely others are as well, and then work with them to help us, develop solutions to those.
Very good. Now they have this agent factory concept that they're working with. Do you see that as something that might be of use to you in your area?
Yeah, the AI, what did they call it? The AI agent factory that they announced last week at the user group meeting was fascinating. I think there are so many promising aspects of that. And then I also have to step back and think of, the same things that I think my colleagues were talking about last week as well in conversations I would have with them. Well, how do we make sure that what we're gathering is validated? How can this help with our workflows? But then when it comes to behavioral health, here's where that additional level comes in of complexity is, in Colorado, for example, we just passed a law that went into effect, I guess, 2 weeks ago now, about AI use in psychotherapy and the need to get written informed consent and what's allowed and what's not allowed. So as I'm thinking about that, I'm also then having to go back and think, well, how does this work with the law? Is this something we're going to need to get written informed consent from a patient to use? Is this something that kind of falls into that administrative task area? And so while I'm excited about it, I also have to think about, how can we use this? How do we know it's safe to use? And what would these workflows look like to even be able to make this happen?
Yeah, very good. So it's really interesting. Ambient documentation, these things that have really taken off and found a lot of success. The idea is they are returning the physician to the care, freeing them up and allowing them to be present with the patient. It certainly seems that would be extremely important part of behavioral care is presence, right?
Yes.
I mean, just at a basic level, it's somebody listening to you, right? So if somebody's on the computer and half hearing you, that doesn't seem like a great environment for therapy.
Yes, I'm hearing from many of my colleagues, because we've rolled out ambient listening in our system, that, not only do they feel more present, but sometimes it's catching things that maybe they hadn't thought about, and they're like, oh, I did want to follow up on that. And again, this is behavioral health, so we always have our edge use cases. There are some cases where this isn't great. We found, for example, with psychosis and delusions, it's not capturing it very well because large language models are based on how language is traditionally used. So if someone is coming in with an extreme kind of psychotic delusion, the language may not make sense. And so if someone's explaining like a really, kind of bizarre religious, delusion that they have, the AI may say, oh, they had, a spiritual revelation in the last week, and kind of gloss over it. But also what's been interesting, and we've just faced this in Colorado, is we found that this is a fantastic tool. And a law just came through that said, well, patients have to provide written informed consent to be able to use this with the provider, and the provider has to obtain it, which means we can't send out a consent form in advance. There's some ambiguity in how the law was written, but in our system, at least, that means we are using the surgical consent tool, which has now been transformed into an e-consent tool. So in the middle of session, instead of delivering behavioral health care, we're having to stop and go through this process of getting them to sign this consent, which is much more complex in the 80% of telehealth visits that we have in an ambulatory practice too.
Yeah, and that makes me think of how detrimental a disruption can be to a therapy session. Any kind of disruption can really, you can destroy the flow, right? And so that to me seems like a real problem.
Yeah,
right?
So it's something we're trying to work around. And then that's where it comes into that question I had posed earlier. Like, so now we've made the response cost of using this technology even harder on, the patient, the provider, the therapeutic relationship. Do the benefits still outweigh the costs of this? And that's something that every provider then has to decide. And this is a particularly problematic in these or more complex in a large healthcare system versus if someone's in private practice, they may, it may be a much more simple solution that they have.
Yeah. So there's a couple ways we see technology can affect behavioral care that's different than traditional care. And what I'm thinking there is, you referenced it with the AI trying to understand psychosis and whatnot, and there's a tendency of the AI to validate feelings and what people are saying that may not be helpful. And I think we've seen there may be some lawsuits out there where these large language models are being sued because somebody wound up committing suicide because their delusions were validated by the AI and said, you're right. And also, we not only have technology and AI being worked in behind the scenes ways to facilitate care, which is all good, but sometimes the AI is actually delivering the care in behavioral care, at least on a public facing large language model, people going to ChatGPT and thinking they're going to get the same therapy for free that they would have gotten from a professional. I guess we do see that on the clinical side, people going for basic. It just seems much more dangerous on the behavioral side. So I don't know. What are your thoughts there?
Yeah, that's something I'm watching closely. I think, and this is where some of this regulatory environment starts to become problematic. So if we're putting in, I don't know the perfect solution to this, but we know patients want this. They're going to this, and there's a reason they're going to it. And so we need to take a step back and think about, why are they going to this? What are they going to this for? And how can we facilitate meeting that need in a much safer way? However, if we become reactive and say, we just won't do that, or we're not allowing clinicians to do that, what we're doing is kind of limiting the practice of clinicians, but then giving that, this unregulated space out there to all of these companies who maybe aren't so concerned about how the patient's going to do at the end of the day to fill those gaps. And so I think we need to, LLMs are going to be a wave of the future. We need to be part of the conversation. I think large healthcare systems do, providers do, security does, all of the different pieces of governance to figure out, what does this look like? How do we meet the need that patients are clearly seeking, but how do we do this safely? And then how do we set the conversation about what these standards for safety should be and how we can do this in a way that helps our patients?
Yeah, we really want to be careful that we don't get disintermediated, right? That we don't have this technology come between us and our patients.
Right.
We don't want that. And so it's kind of interesting. Um, let's say we're talking about an Epic shop, and they all of a sudden my chart became the point of interaction between
Hmm.
patients and health systems. My chart is a vendor provided tool. That's
Right.
not your health system. That's Epic's tool. You can customize it a bit, but it's still an Epic tool.
Right.
If you should decide to go with another EHR vendor, you would have a different tool. So that's a layer of slight disintermediation. Now what we've got is you can get ChatGPT Health, and you could have that integrated with your multiple MyChart accounts. So now
Yeah.
perhaps there's a new layer now on top. So you could
Right.
have ChatGPT Health, then MyChart, and then the health system. It's just an interesting world we're living in where everyone's trying to sort of get upstream. I think
Right.
of this analogy in my head. It's like if you buy a condo and you think you have a beach view, and you bought the high rise, and then the next thing you know, somebody put a building in front.
Yes.
So you want
Yes.
to make sure you're close to the beach. Does that make
Yeah.
sense?
Yeah. Well, and I think that's, we've got to slow down at some point and just say because we can doesn't mean we should when it comes to technology. And I do feel like, and this is just in the larger healthcare domain. Anyway, LLMs have been a game changer, right?
Hmm.
Agentic AI is an absolute game changer, but the possibility is exceeding that kind of pausing and saying, does this make sense? Like, just because we can do this and it could enhance care in these ways, we still need to pause. And that's why governance is so important. We need to pause and think, why are we doing this? Are we creating more problems, or do we understand what it is we're putting in here? Or is this just making things worse? And consumers need to think about that too. If they're opening up, ChatGPT Health to all of their medical information, like, what is this solving? And is there a better way to solve it too?
That's a great point, and I'm laughing because this is right in line with what I'm thinking. I think there's a huge amount of FOMO going on
Yes.
in conjunction with and due to the Epic user group meeting.
Yeah.
So
Oh,
I
interesting.
really do. I really do. If you follow things like I do, um, so I got a lot of connections on LinkedIn, and
Mhm.
I keep an eye on their notifications. I don't think there's any event that spurs activity like the Epic user
Yeah.
group meeting. I don't think, hymns. I don't think Vive. So I think we have this. And this is growing every year
Right.
over the last 15 years, and we're at the apex unless it's going to keep getting bigger.
Right.
And there have been people writing about this. There have been some posts about this. You have a flood of things coming out of Epic and everywhere else.
Yeah.
And as you mentioned, there's a million things to do. There's a million things. Everybody is saying they're doing one thing, which sounds like you should be doing like you feel like you're falling behind. If I'm
Right.
not doing a million things, I'm falling behind. I'm failing my health system, which
Right.
I think is completely incorrect. It's
Right.
just this perception that everybody's doing everything, but I don't think that's true.
Well, if you're doing everything, you can't do everything well, right?
Right.
I mean, so
Right.
yeah,
So
I
there's
agree
this
with that.
sort of, I think, as you mentioned, this kind of calm down, get off social media, stop getting FOMO of what it's sort of a
Yeah.
traditional social media effect. I'm falling behind. What's wrong with me? So I think
Yeah.
everybody's got to just calm down. And as you said, what are our problems? Where can technology help? Not, oh my God, everybody's doing everything cool with all this technology and I'm nowhere.
Right.
Does that make sense?
It totally does. Yeah. I think, and they're kind of probably going off the ambient use case. I mean, ambient listening was a game changer, absolutely, for reducing burnout, for quality of, notes and compliance with closing notes on time. I mean, it has been absolute game changer.
Hmm.
And it got to the point where, I think healthcare systems were saying, if we don't implement ambient listening, if we don't get on board with this, we are not going to be able to recruit, or we are going to start
Right.
losing people because this is so important.
Right.
That met a clear why. There was
Yes.
such a clear need for it.
Right.
But we're taking that mentality as it applies to all these other things. And you're like, well, incrementally, how much is it adding to do that? It's not the same as Ambient. And I haven't heard of any technology out there right now where people are like, if you don't have this, I'm going to leave this healthcare system. And I think the more that we do, the more we start wondering, like, are we going to burn providers out if we're going too far into the adoption? Because again, everything that you adopt, they're going to have to learn. There's going to be regulatory, there's going to be governance over it, and it's going to be more complicated. And the systems have to upkeep all those pieces too. So.
And I think your reading of that is 100% correct. I think what you have is what you said, which is a perfect tool for a perfect huge need,
Mm-hmm.
which was great. But then people like the hammer and the nail, right? You had the hammer, you had the nail, it worked beautifully, but now people are walking around with a hammer going, what else can I use this for? And they're trying to hit screws with it, and they're doing all sorts of things that aren't going to work. You're right. That I think you combine that with sort of the UGM kind of FOMO thing. And I think there's just I feel like there's a lot of excitement, but a lot of anxiety, and that people can have the perception that they're falling behind because everybody seems to be doing all this amazing stuff, but it's just blocking and tackling, right? Do what needs to be done, good governance, find out what the users need, and then you're working within some constraints, which is what you mentioned, constraints of integration, constraints of expense, and all that. And then it's the transparency back to the requesters of if and when and why something is happening or not happening. Talk to me a little bit about that.
Yeah. So kind of the workflow of when someone wants something done.
Yeah, I mean, because as you said, it may take a little time, the governance process, right? So if I'm sitting there, I feel a lot better if I know where it is in the governance process. Maybe I'm not upset that it's taking a little time, but if nobody told me it's going to take time, then I start to get a little anxious. I think IT doesn't do anything. They take tickets and throw them in the garbage, and nobody's listening to me. And we don't want that. We want to know people are listening, they're looking at it, and if they say no or not now, they want to know why.
Yeah, I think there's two things I would say about that. First of all, we need to educate these requesters how to make a better request.
That's good.
Because you need to state what problem this is solving, why it's a problem, who it's impacting, that it's not just 3 people in one clinic, that this does have implications for the larger system. I talk a lot about using kind of a one-pager when you're making a request. What is the problem? Why is this a problem? What are you proposing? How does this address it? And what would be next steps? Because that's a lot easier for me to take to governance and say, okay, I've got this. This is going to go here first. I'll let you know what happens next. But a lot of times, if I'm getting kind of this one-off request that's shot to me in an email, I am then having to kind of take it to our committee and say, okay, we need to put in a request for this, but I'm not even sure how big this is. There's like 6 meetings that happen to get a sense of the request before we can even figure out how to move it along. So that's one side. So one part, I think, is better education for those who are making these requests. Really with this idea of what is the problem, what are we trying to solve? I do think sometimes governance can be overly complex, and it is not uncommon that I go to, one governance committee, say there's something in ambulatory, and they're like, oh, yeah, and I think that's the last step. And then I'm told, oh, you have to go to HIM for this, or you probably need to loop in our, inpatient governance because it has this small implication for something they're doing. And so you don't always know what that process is going to be until the conversations happen. But it is funny because a lot of times you have the same people at these different who are representing in these different meetings. I don't know the solution to that, but I do think that it's worthwhile at an organizational level to keep coming back and saying, is our governance structure working? Are we making it overly complicated? Are there ways to streamline? And make sure that, you're not, if you have the same 3 people and one additional person sitting on each committee, can you just have that one additional person and just do one large meeting, for example?
Yeah, I love that. And I've always wondered and be curious about if and how organizations have oversight of governance with an eye towards continuous optimization of what's inefficient, right? So, because it's a weird thing. It's like if everybody who can make decisions is in the governance process? Who's looking down upon the governance
Right.
process? Who can say, this individual no longer needs to be in this committee?
Right.
We're missing an important voice in this committee. Or, as you said, these two committees overlap 90%. Can we create one committee?
Right.
That's really important. Otherwise, I think it just gets stale and old and inefficient, and that's not good.
Yeah. And I think all these committees need to know what are the system level priorities at this point, because there's a
Right.
lot that we could do that could improve care, but we have limited resources, right? And so they need to also be keeping those in mind too. So, for example, at our institution, we have an executive representative on every governance, which is really helpful because they can put it in this larger context that, maybe this is great, but it's not one of our biggest system priorities right now. And so it has to go lower down the chain, instead of getting approval, and then someone vetoes it after you've done 8 weeks of work on it.
All right, Dr. Dempsey, we're almost out of time here. I think I'll ask you this as a final question. Again, I'm very interested in bridging the gap between, let's say, the CIO and someone like yourself who is going to be leading up the optimization of informatics from the behavioral health side.
Mm-hmm.
Um, I don't know if every health system has someone who's doing that on the behavioral health side. If I was a CIO, I would probably suggest, or I'm thinking that some advice might be, make sure you build a bridge there to that
Yes.
unit. And maybe there's an obvious person, maybe there's someone in that role, but if not, you might want to have that as a goal, to have someone who is going to head up that relationship between enterprise IT and behavioral health. I'd like your advice for the IT executives or someone in behavioral health who's doing this, who doesn't feel like that bridge is as strong as they'd like it to be. So you could take it
Mhm.
from either side or both sides one at a time, because I think we want to make sure that bridge is there.
Yes, I totally agree. And I think that person also needs to understand. So they need to be able to speak on behalf of the providers. What are the problems that they are facing in the care they're delivering? But then they also need to interface with the service line or kind of the operational leadership. And those two aren't always interacting with one another, but are they understanding the regulatory environment, some of the pressures that they're having to face, what the Joint Commission wants to see, for example? So they have to have some understanding of that as well, and put those two pieces together to what's possible in the informatics and IT space as well. So that person really is kind of a translator between three different
Right,
groups that normally don't talk to each other very well.
right, right. Very good. All right, Dr. Dempsey, this has been an absolute pleasure. I want to thank you so much for your time today, and I hope we can catch up again down the road.
Likewise, thank you so much, Anthony. Have
Have
a
a great
great
day.
day.